20th. And we have with us this morning representatives from Bi-State Primary Care. They're gonna tell us about the great work that they do. So you all three wanted to come up together, right?
Yeah.
So if you all want to come up.
Get that.
Clifton's going to show you.
Yeah.
You're good.
Good job.
What was that?
No, he's not in.
Good morning.
Good morning.
Good morning.
So we didn't clue Michael into this, but we elected you to lead things up.
Oh, no, you're welcome to.
So
The guy in the middle, right?
why don't we do introductions and then we can kind of go from there. So I'm Jeff McKee. I'm the CEO of Community Health Centers of Burlington. And yeah.
I'm Chris Found, the CEO of Northern Counties Healthcare in the Northeast Kingdom. Good morning. My name is Michael Acosta. I'm CEO of Gifford Healthcare. Gifford is a federally qualified health center, critical access hospital, and senior living community based in Randolph, Vermont, but with clinics throughout central Vermont.
So yeah, we didn't coordinate this, so we'll kind of do our particular pieces, but within the community health centers serving Chittenden County and Southern Grand Isle County, we have 9 locations. And we are, within a relatively small geographic footprint. And the reason we're in all those locations, which doesn't make a lot of business sense in some ways, is because of our belief in our mission, which is to improve the healthcare of all, and our focus on health equity, which requires us to do a lot of things that other primary care doesn't do. So we do not, FQHCs, do not turn away people because they can't pay, right? We also really lean into providing care that no one else will provide. We're often consider ourselves the last mile of healthcare. So we have we're the state's only federally recognized healthcare for the homeless program. And so we have people, in addition to providing integrated primary care, mental health, substance use disorder, dental treatment, we also have people who are putting on backpacks and walking downtown in Burlington trying to engage people, who are walking into woods in encampments and trying to engage people in healthcare. That's part of what we do, part of our mission. Most of that is not supported by various kinds of billing resources, Medicaid, Medicare, or commercial insurance. We get a little bit of money from the federal government to support that program, but not nearly enough to cover all the services we provide. And that's one of the reasons that we're here today, is to really kind of talk about the state of where we are as a federally qualified healthcare system, in addition to our individual centers. Many of us, many of the FQHCs are really struggling to have operating budgets that sustain us into the future. In our case, we're at about 54 days of cash on hand at the close of last month. We're losing 2.5 days of cash a month. And so that is, we know that the state is not responsible for picking up the entire tab, but that's the situation we're in, and the state has a big piece of that work that you all need us to do. I think the kind of relationship the federally qualified health centers have had with the state over many years is that when there needs to be something done around healthcare in the community, we find ways to say yes. Increasingly, we're really challenged to be able to do that. I'm going to come back just to the 54 days of cash on hand. You might hear from other organizations that they have fewer days of cash on hand than that. Some operate with 20 month to month for long periods of time. We have 54. The challenge is not necessarily that we're at 54 days. The challenge is that we're losing 2.5 days a month. And so that's, and I can't fix that without closing practices or doing other kinds of really dramatic things that reduce our commitment to our mission and our commitment to the communities we serve throughout Chittenden County. That's the only solution I will have going forward if we go another year without funding that will support us. And so it's really quite a dire circumstance in Chittenden County for us to be able to sustain the work.
May I ask, what is one day? How much
A day for us is about $120,000. Yeah, so we're losing about $250,000 to $300,000
Every month.
every month.
Have you, I think the key is that if we lose you, patients go to UVM Medical Center, right? And so have you done any type of analysis of what that cost to the system would be if that's where people went?
Yeah.
That makes sense.
That's a great,
Probably hard to do.
it's a great question, and you're talking about kind of the money you didn't spend.
Right.
Right, but we do know that we, particularly for the populations that we serve, that we lean into, heavily Medicaid, heavily uninsured, heavily transiently covered by insurance, that those folks have higher utilization of the hospital as it is, and if we weren't there providing that care, it would certainly go up.
Thanks.
But we, I don't think we've done.
That's fine.
So in the Northeast Kingdom, it's a very similar story to what's going on over in Chittenden County. Northern County serves the Tri-County region of the Northeast Kingdom, covering 2,000 square miles. So it's a pretty large area, and it's a very rural area, especially a couple of the members here are intimately aware of. In fact, we are the only provider of dental and primary care services in all of Essex County. It was our very first location up in Island Pond. And in Island Pond alone, we serve nearly 100% of the residents in that town. And it's sort of just kind of out from there, kind of trickles down. We have the same challenges. We presented a budget to our board last night that's projecting nearly a $1 million loss for our next fiscal year. That's not sustainable. And I agree with Jeff, we're not asking the state to pick up the full tab, but we are asking the state to do their part, and particularly the Medicaid population. We're serving 40% of the Northeast Kingdom's residents in our primary care sites, which is a pretty large portion, many of which are on Medicaid. The rising cost of providing care is what's driving this. Even before COVID, our reimbursement was not covering the cost of providing care. We've seen around a 25% increase in nurse wages since the pandemic. This year alone, our healthcare expenses rose 22%. Those are things that are contributing to the ongoing care cost of providing care. In addition to what Jeff said, when a patient walks in to receive care from us, we're not just providing them with primary care. Federally qualified health centers are addressing all of the social contributors to health as well. And so we have folks that can help if people need to be connected with fuel assistance, transportation, mental health services. We do have embedded mental health in all of our primary care sites, including therapy and psychiatric care as well. And so it really is a more holistic approach to care. I'll turn it over to Michael and a little bit of a heat. Sure. Gifford.
So Michael Costa again, CEO of Gifford Healthcare. We are a little unusual. We're both a federally qualified health center and a critical access hospital and a senior living community with independent living arm, a nursing home, and an adult daycare. You wouldn't set out to design a healthcare organization like that. Like a lot of Vermont healthcare organizations, you evolve to meet community needs. The story of Gifford owning a nursing home is because the nursing home is going to close. So we stepped up and did that. Story of adult day is, nobody else was doing the community. So we did it. Story of independent living is that, there are people that love this community, but kept moving out once they got to a certain age. And, I think for a long time in healthcare finance, the way Gifford worked was that the hospital could subsidize these things that lose money. I started about 4 months ago after spending 5 years at Northern Counties Healthcare. And before that, I was Deputy Director of Healthcare Reform for Governor Shumlin and Deputy Commissioner of DEVA for Governor Scott. And it's a really tough time right now. So 9 years ago, Gifford had 250 days cash on hand. Right now, we have 73. We had our best month since I started last month, and we lost $740,000. We are doing lots of things to try to stem those losses. For example, we restructured our staff. We eliminated management positions. I eliminated 3 senior leaders on our management team, including vice presidents, because all of our savings can't come out of patient care. As this committee well knows, the supply and demand curve in healthcare has not met. Whether it's FQHCs or independent primary care, people need access to healthcare services. So we're trying to figure out how to do that while keeping our lights on. Now, FQHCs are very particular things. They started in the 1960s as part of President Johnson's Great Society initiatives because there was an observation that, well, primary care worked pretty well in suburbs where there was lots of money. If you lived in the inner city area or a rural area, it really didn't work economically. And so you got a couple things. If you agreed to all the rules of being an FQHC, including taking anybody regardless of ability to pay and offering wraparound services, you got some advantages. You got a grant from the federal government, you got a particular payment methodology, and you got some help with your malpractice insurance. That grant funding has not gone up in 10 years. The feds used to routinely increase that grant funding, which was meant to acknowledge that these things are very hard to run sustainably. But they've been eroded substantially given inflation, particularly the cost of staff. And then also the 340B drug program is under attack by pharma. And so our 340B, when I left Northern Counties the last year I was there, we had lost over $1 million in 340B revenue that we had to find. And Gifford is suffering with that too. And so it's just becoming increasingly difficult to sustain patient care when the cost of every visit exceeds the revenue we're paid for it. Like Chris and Jeff, I agree this is not entirely the state's problem. We're not looking for Medicaid to underwrite losses, but help with our rates to reflect the rising cost of reimbursement would be very helpful. I also, just speaking for myself, particularly with the hospital hat on, I know we need to look in the mirror. And that's what I've tried to do in my 4 months here, to say, hey, like something needs to change in Vermont's healthcare system. And we need to be part of that. It's not enough to say, well, we're good people doing good stuff, so nothing bad can happen and nothing can ever change. Like I think in my leadership of our hospital, I'm trying to challenge every piece of our administration to be more efficient and to try to keep costs down so we know exactly what the help is we need to get to make sure we continue to offer patient care. Now, the hard part right now in healthcare is that everything feels super urgent. I'm trying to remind my own team that there's stuff we need to do now, stuff we need to do in the near term, and there is a future to plan for, right? Despite the fierce urgency of this moment, we need to try to make investments that are going to pay off in 2, 3, 4, 5, and 10 years. And so the other hat that I'm wearing today is as CEO of the Maple Mountain Consortium. The Maple Mountain Consortium is an effort by Vermont's FQHCs to run a primary care physician residency program. Because it is dreadfully hard to recruit physicians to primary care at all, never mind to health centers instead of UVM or Dartmouth. And so a consortium of FQHCs went out and got a teaching health center grant. This is where HRSA provides you with grant funding to start your own residency program. We just had the site visit to be accredited for that. This was originally born at Lamoille Health Partners. Lamoille has hit some very challenging times. And so they were going to end the residency program. They came to me a couple months ago and said, do you have any interest in trying to keep it open? We said yes. That was an interesting conversation with my board of directors. I said, I know I've been here 30 days for $1 million a month. Can I please start a residency program? But they said yes, because it's really important to have physicians. Replace them. It's going to be really hard to continue to offer primary care. And so I want to give credit where credit's due. We went to the state Medicaid program. We went to One Care Vermont and said, hey, I used to be deputy commissioner. I know you got buckets of money in there somewhere. And so One Care is able to take money that it's supposed to be investing in innovation and provide us with 1.5 years of grant funding to try to do all the things we need to do to be certified and up and running and start recruiting physician candidates to do their residency here. The folks that certify a GME program were on campus in Randolph in January. We're waiting for their results. We're very confident that we're going to get the green light to start a residency program. We need some help with that workforce program. Over the course of 4 years, it probably requires about $4 million. And so we're looking to see if the state legislature would be willing to fund that workforce program. And I have something I can leave with you to talk about it. I'm also joined here today by Nicole Marcheter, who's the director. I'm trying to keep to basically air traffic control, trying to keep that going because running a consortium of multiple FQHCs is not easy. And then Dr. Josh White, who is our medical director at Gifford and a practicing emergency physician for us, and is, helping lead the effort to get the Maple Mountain Consortium up and running. I think it is really important to tell our staff and our communities that no. We know things are hard right now, but we plan to be here for the long term. And we're trying to recruit mission-driven people that want to be here as well. And I want to be respectful of the committee, but I'm sure Dr. White is happy to talk about the importance of residency training if that'd be useful to the committee.
Sorry, can you
No,
just,
no.
$4 million over 4 years, so it's one-time funding or ongoing?
We are asking for it as one-time funding because you can bill with residents. And so we know that generally with residency programs, there's a ramp towards self-sufficiency. And our projections is that gap gets smaller over time. We just don't know what year 5 of the program will look like. And so it's basically ballpark $1 million or so a year for 4 years. But we need some certainty that we're going to keep the lights on, right? Because we're asking residents to commit multiple years of their lives to this program.
Thanks.
And you have a proposal for us. Okay.
Yeah.
Woody?
I was just going to say, this is not this consortium, this teaching residency program. It's nothing new. We've been there before. What is old is new again. Does Gifford have a history in the past regarding this type of program? A lot of local hospitals did this in years past.
So Gifford has a long tradition of taking on students, right, who come through, and then in the deep past, we spent a lot of time training nurses. But there's actual training of physicians. I would defer to Dr. White.
So Gifford does not train its own residents now, nor has it in the past. However, as mentioned, we have a long history of education. We partnered with UVM for their medical students, their residents, and their nurse practitioner graduates. We partner with Dartmouth for the medical students and their residents. We partner with Franklin Pierce PA program, various nursing schools to include the State University. We partner with various paramedic programs. And we have our own programs. We train medical assistants for instance. We have a significant depth of education, although historically it has not been resident specific.
Wait, I'm sorry, you have agreements with Dartmouth and UVM. You mentioned with residents, so do residents do like a rotation?
It's dependent on an individual program, and some of it is ad hoc when a different student expresses interest. Some of it is scheduled. And so at UVM, for instance, their students rotate through our pediatrics department. Dartmouth, their students rotate through our emergency department. And it will oftentimes depend on the interest of the student.
Yeah,
Go right ahead.
no.
If I may, so one of the things that I think you get with me, if you're Gifford Healthcare, is between health policy and Medicaid and an FQHC and home health agency in Northern counties and now Gifford, is thinking about how the system works together. And so I to be frank, I tried to be really hard with my team over the last 4 months to say, look, particularly with the Oliver Wyman report, why is Gifford important to the system? We have to find ways that we're important to the system. And so one example of what we're doing is we do a call every single day with Dartmouth to talk about the state of their emergency department and the state of their inpatient census. Because they will tell you about a quarter of their admissions every day are for people that need hospital care, but don't need to be at an academic medical center. So we've become very successful at pulling patients from Dartmouth to Gifford. And so I bring that up to say, we think we can be systemically important by being like a relief valve. If people are stuck at Dartmouth, and then hopefully if we develop the same relationship with UVM, we can say, look, we have capacity. Let us do that. Another way we're thinking about that is teaching. We know that in any successful version of the future, that we're going to need more primary care physicians. Like, can Gifford and its partners step up in that role and say, hey, one of the things we do for Vermont's healthcare system is train physicians. Because all the data suggests that you stayed pretty close to where you're trained, right? When we were at Northern Counties, we loved our dental program. recruiting dentists is wicked hard. Maine has a lot of luck with it because they had a program where they train dentists. And so we're trying to figure out ways that we're not just another blue H in Vermont, some demographic challenges. Why do you need to sustain all these institutions? We're trying to take a real look at what value we can add, not just to Gifford, but to the whole system. And we think physician training is one of those ways.
You have an agreement with Dartmouth Hitchcock, but not UVM
So this is, we don't have an agreement with,
beds.
so we don't have an agreement with them. They simply, when I started, I went to them and said, hey, look, I'm really curious. You had Alice Pectet in Lebanon, in New London in New Hampshire, that went a really bad space. And now they're doing better. And we have empty beds at Gifford. And this seems weird because people are stuck in this system. And they said, yeah, we do this call every single day with our network members to try to better allocate people throughout the region. And we said, can we join that, even though we're not affiliated with you? And they said, yeah. So they just treat us like an affiliate member, even though they don't do that. We made a similar offer to UVM, not trying to criticize them. I know they have a lot going on, but we're very anxious to have the same type of relationship with CVMC and UVM. And you can't force people to go. Someone has to decide they want to go. But if you're from Braintree and, the EMS took you to Dartmouth, but we should have really brought you to Gifford, let's bring it back. Or we do see patients evolve where they start with us and then they need something that only Dartmouth can do. But then there's no reason for them to spend the whole week there. We offer great care, we can pull them back. So it's not a formal affiliation, but they've been nice enough to say, hey, we want to work in service of the system. We know that there are too many people come to the tertiary care center. Let's just treat you like your other network members and pull you back. I'm trying to really impress upon the team that we cannot do things the same way as we've always done them. We need to find different ways to run this health system, or you're at risk of having pieces of it fail, which I think would be really bad for Vermont and Vermonters.
So, I had a number of individual conversations with folks about our work that CHC has had with DIVA over the last now 26 months, applying for a change in scope adjustment to our rate. So that process would look at very significant kinds of events that you've had in your history that would qualify you for a change in your cost per visit that could result in a new Medicaid rate. That process is still ongoing 26 months later. We're still negotiating the way the formulas work in the spreadsheet, of which one we had been sending back and forth for months, and many errors in it, and we had to correct those. So 2 months or 2 years plus in that we've been trying to ring this alarm bell, and we're getting closer and closer to the edge that we've been in this process. That process has been expanded. We applied for a change in scope. We were the first FQHC to do that. Subsequently, the DIVA has taken on that change in scope adjustment for the entire set of FQHCs. That really has not moved us forward at all. I just want you to know that we're still working through that. To date, any of the answers some of the FQHCs have received results in no change in that rate based on the formula the state created, resulted in no change. And I think the people that we're working with at DIVA really understand our mission. They understand how valuable we are to the system, but they're also just kind of stuck with the budget limitations that they have to work within. And that's why we need you. They can't allocate funds to us that they don't have. And yeah.
Well, let's let Chris, and then Lori has a question, and I see Leslie.
Thanks. I wanted to circle back on Representative Hogan's comments around kind of the bleed and the cost of care. Yesterday morning, 40 minutes into opening our Express Care location in downtown St. Johnsbury, we had 14 patients in the door. Those are 14 patients that would have gone to the emergency room. Those 14 patients would have cost Medicaid and us taxpayers more money. So what I worry about, and I think the clear message that we're trying to send, is that we need to invest in primary care. It's the lowest cost care in the state. If we lose our FQHC network, which provides care to 1 out of 3 Vermonters, it's going to cost us more money. We need to invest in primary care so we can be sustainable. We have lost FQHCs in the past year. We've lost them in the past month. We have one closing, I think tomorrow it is in Stowe. We have to invest or we're going to ultimately spend more money on healthcare. And so I don't have exact numbers for you, Lori, but we all know that's a known, it's known. And that's in the short term. The other thing is the long-term cost of care, where as Joan, investing in primary care is the right thing for long-term health outcomes. So.
Well, I apologize because I have to step out, but I have one question. Have you gotten any indication from the federal level if your funding is in jeopardy?
I mean, so we've received no indication yet. It's very unclear, as you know. The previous Trump administration, FQHCs muddled through, and they've asked the same person to lead HRSA this last time.
Okay.
But we are really anxious about what conditions will be put on our grants. So we haven't seen that yet.
Thank you. And I apologize that I have to step out.
Leslie?
Let me regroup. I'm just worried, I guess. And I think the FQHC model for care is incredible, and you talk about that. I'm worried about the FQHC funding model, which sounds like it's really tenuous. So how much Medicaid, and I may have missed this, are you asking what kind of increase? Because you're talking about our budget right now, right?
Yep.
I'm wanting to make sure I understand what the calculations are, and I believe we're talking about a $5 million investment in the FQHC.
So 5 million in state funds.
State funds,
That'd be
yeah.
grossed up.
Yeah.
Which represents about a 20% increase in rates.
And that's what you talked about yesterday, so
Yes.
it's the same thing. Okay, so if that's the.
I keep calling it the case rate, even though I know it's a different
Yes.
So we have bundled rate.
Encounter rate.
There's all these other things, right? Yeah.
counter rate.
Yes.
And
Right.
where I struggle with this model is, we talked about this before, is that you get paid by episode. So it was a great example, the sore throat equals the all-day management of someone detoxing. Is there any movement there? Is there any way to rethink that payment model?
I'm sure there is. I just want to maybe put a little bit of a different kind of broader explanation onto that encounter rate and what that means. So that encounter rate is a mechanism for us dropping a bill, right? That we had an encounter that qualifies, but included in that payment is not just the services that happened in and around that visit. It's all of those other things we talked about. So we do kind of get those discrete encounters, but you can't really match that in what we're getting paid for and what that is intended to include with a CPT code you might bill in another kind of healthcare setting. It's not an apples to oranges or apples to apples kind of a comparison, because it includes patients who can't pay. It includes all that outreach, all the case management. In our case, it includes 10% of our services are interpreter supported services. Fully 10% of every visit we have requires an interpreter, 22 different languages. There's no other payment for that just goes into to look at those high volume clinics.
Just really quick, does Medicare pay an encounter rate, or do they pay?
Pay on the encounter, yeah.
They also, so it's just Medicaid and Medicare.
That's paying up.
What's Medicare's encounter rate done over the last few years?
It is not kept pace. It's even further behind than Medicaid.
Okay. I'm sorry, Michael.
So
I think Michael wanted to.
What I
really-
was just saying, Representative Goldman, so federal law sets a methodology for Medicaid
Right.
to pay FQHCs. I'm not aware of any effort at the federal level to change the law around how FQHCs are paid. I would say, though, underneath that, the essence of that federal law says, here's how you pay FQHCs, or states, you can set your own way of paying FQHCs as long as you don't pay less than the federally required minimum. And so the state Medicaid agency would have a lot of freedom in how it sets an FQHC rate, provided it sufficiently funds it. And Jeff is correct. We've spent over 2 years now trying to be good faith partners with DVHA, saying, hey, can we figure out, make sure that we're being paid in accordance with the law and paid a sufficient rate? And the discussions are cordial, but they just haven't led to a resolution. We're seemingly always 3 to 6 months away.
Right,
Some final.
and just with full disclosure, I'm from Bellas Falls. So,
Yep.
North Star, of course, has, withdrawn from Bellas Falls and really abandoned our community, in a very unpleasant way. I hope that what's happening in Stowe, they did a better job. So I'm a little cynical, for want of a better word, about the funding model. And hearing what you have to say is not reassuring me. So I'm not sure when we think about investing state funds, are we investing more state funds in something unsustainable? I totally understand your work is fabulous. I know that, and we've heard it. But my response, I'm struggling just because of this, of closures anyway. Now, I know you want to prevent more closures, but will it? I'm not convinced.
I appreciate your cynicism on this. I think for me, when you're up in Island Pond providing primary care, this is really Chris's beat, but I just spent 5 years there. What's your alternative?
I get it. But I'm talking about your model is great. You give great care. It's not about that.
Yeah.
It's about sustaining it.
I know. I just think that we recently did due diligence on taking over one of the practices that UVM has decided to abandon in the map. I know independent groups took a look at it as well. And they all came to the same conclusion, like we just can't run these.
Afford it.
Yeah. And so I just think, all of primary care is struggling with that right now. But I appreciate your question.
So in our case, so we have 9 locations in a relatively small geographic area. And in fact, it's one of the things I explain to new employees when they come in is that you can go upstairs at our Riverside Ups in the old North End in Burlington, and you can look out the clinical pod window across the Winooski River, and you can see the rooftop of our practice in Winooski at the O'Brien Community Center. And the question would be, why do we need to be in Winooski if we have capacity in our building, which is 4 miles away, or less? If you take the long way around, it's that far away. Why can't those patients just come across the river, come and get their care there? It would be a better business model, right? Clearly, it would be better business, lower infrastructure. It's really about, is the state really committed to health equity or not? If we're not in Winooski, if we're not in all the small communities, we're not in downtown Burlington, in addition to being in the old North End, there are patients who will choose not to get their healthcare needs met. It costs more down the road. We create health disparities increasingly by not being in those communities. And most other healthcare institutions, hospitals included, make business decisions about where they go in and lead with that, about where they put their practices, where they can get enough patients to do that. The only way to get those small communities, to get a practice in Bellows Falls or to get into the smaller communities, is to fund the FQHC model. That quite literally is the only mechanism we have in place in the state of Vermont to get those services to those small communities or communities that would otherwise be underserved. And that is what is at risk, in my opinion.
Yeah, if I could, yes, of course, except not in Bellas Falls or Stowe. So the question is, for me, it's like consolidate but not abandon. And I'm trying to think about how people can do that if there was a really robust transportation, that people engaged with the community to really say, okay, we understand,
There's the nuances of how I get, I don't know.
But that's where
the
it's
detail,
in
right?
the detail, right?
Yeah.
And the fact that was ignored, that our community was ignored, people are suffering and not getting the care. And it is going to be more expensive because they're not getting care.
Yeah.
So I'm sorry that I'm taking it out on you. But I'm frustrated about when it spreads to other communities. Are people going to be thinking about who's left behind and how they're going to get care?
Yeah.
I think Daisy has a question and Topper has a question. So I really want to make sure that we get to everybody.
Thank you for your point about Winooski. I'm a patient there, and I'm so grateful that you're there for our community, many of whom would not cross the bridge to Burlington. My question is one about funding, and I'm curious if you're designated as an FQHC, are there other, maybe not federal designations, but are there other ways that you could bill for patients or services to complement your billing structure? So our designated agencies, for example, they have supplemental programs, grants, et cetera, that really supplement some of the state funding and federal funding that really does not meet the cost of delivering care. Are there other ways that you can supplement FQHC funds?
I think that's really challenging for us because we do have that federal mandate that sets the rules for FQHCs. I think if in a more targeted way, if Medicaid wanted to open up billing pathways for additional services, we'd certainly be open to that conversation. But it really is a bundled rate. You can't kind of start to take out different pieces of it and say, we're going to try to pay for you that thing separately over here if it's part of the scope.
I really appreciate the question. I do think that my observation now, having worked for a couple of FQHCs, is that we're not great at billing for everything we do. And so trying to encourage people we provide, for example, great care management. There are some other codes that you can bill to pull down that money. We also scrutinize every single grant opportunity out there. And so I think that's part of what's needed with an all of the above strategy. I think one of the things that we try to stress to our own team, though, is even though we're an FQHC, the majority of the revenue that we produce is the old-fashioned way. People need care, they come in, we submit a bill, we get paid. And so increases in rate have a dramatic impact. We need those other funds, but that's still the primary way we get paid and like the most helpful way. But we're out there scrutinizing every other opportunity.
So for example, I just ask a follow-up. For example, I've mentioned this in here many times before. If you were to become a designated collaborating organization, a DCO with one of the CCBHCs in the state, could you bill for, say, mental health services that you're doing or primary care services in an FQHC? Could you bill for that same patient through the CCBHC and get that higher FMAP rate?
Yeah, we do that in various centers, have different kinds of relationship with partner agencies, and we do that already. And so, not with the CCBHCs because they're not fully, that's not fully developed, but that idea that we would place clinicians in schools or in other agencies, or we, in our case, because we have the homeless healthcare program, we will go wherever there are people who need that care, and we will bill under our umbrella, even though we're providing that care in their location, right? So that's kind of
And you can get a higher rate doing that.
We get our standard rate. There's no difference in what we get if it was office-based or if we do it at a homeless shelter.
But the CCBHCs get a higher rate than FQHCs.
Yeah, I'm not sure where that stands at the moment. So we would have to bill, we could lease our staff to them to draw down that higher rate potentially. And I think, at least in Chittenden County, we're having a lot of those conversations. The mental health urgent care collaboration we did as a prime example. We're all bringing our different resources to that and saying, how do we leverage the most federal dollars into the community and who should be doing what based on what we can bring to the financial picture for those kinds of things. So I think those things are happening.
Yeah, I'm just thinking about the future potential of collaboration there to squeeze every bit of those federal dollars, God willing, in order to get every last drop of that higher FMAP rate.
Yesterday afternoon, Representative, I was meeting with Melanie Gidney, who runs Claire Martin Center, 3 o'clock, having exactly these discussions. So I appreciate your question. Vermont superpower should be collaboration. And so we've got to have these conversations.
Thanks. I know Gifford has a presence in central Vermont. Has Gifford signaled that they're in trouble financially in central Vermont? And I'll tell you now why I'm asking that question. I got a letter last night from UVM Medical Center, the network, saying that all of the primary care people in the hospital, that includes the mental health, all of them, they're all going out into the community to 3 places. And I'm sure that's going to have an impact on Gifford.
Mhm.
I mean, when I read that, I said, whoops.
Yeah, they're going out as in like they're offering clinics or like
They're going out to the clinics.
Okay,
They're going into the existing clinics that they have in Barry and right around the corner from you in Berlin.
yeah, and so I think Representative, what you're talking about is as they close other clinics, then those people are moving to other. Their UVM is closing a couple of clinics and they're moving those providers to existing clinics. Is that what you're talking about?
No, all of these, it's my primary care office.
Yeah,
Everyone in that part of the hospital,
yeah,
that primary care, I don't know if the others are going, the other people there, but that whole wing of the hospital appears to be going out into the
Oh, okay.
community.
got it.
That's gonna have an impact on the FQHC and GIF.
Yeah, so, I mean, I think we're trying to be really straight with people about our financial challenges. I don't think there's any use in hiding the ball with policymakers or community members that Gifford has financial challenges. I know that we still have a wait list for care and we're working through those wait lists. And so I think when it comes to primary care, that supply and demand curve have not yet met. And so, we keep an eye on what UVM Health and CVMC are doing and because we have clinics in Berlin, both primary care and specialty clinics. But so far, we still see strong demand for primary care services. I mean, I think overall, Gifford has to go through the process of evaluating, hey, does our geographic footprint make sense? Particularly our Berlin clinics are like within seeing distance of CVMC. But when it comes to both primary care and specialty services, Vermonters are still waiting for care. And so like right now, we still feel like we feel like we're going to be okay in central Vermont.
Well, if just what you just said even further, I feel that there's a move there. If you have people waiting, they're gonna pick them up.
Yeah.
People aren't gonna wait.
We have done a really good job in the 4 months I've been there of eliminating most of our waiting list, but we still see strong demand for services. But I'm concerned like you of like, hey, does our geographic footprint make sense given UVM Health's moves, right? I think, Gifford, like every hospital and health system needs to figure out what its core mission is and like what's the best thing it can do to help Vermont's health system. But we also, I think, offer great high quality care. And so we've been doing a lot of discussion of, hey, if your patients are waiting months and months to get into Dartmouth and UVM and they can get into Gifford in a couple of weeks, like that would be a more effective allocation of resources, like for the whole system.
So it begs a question maybe about could we see more volume, right? And make our practices more self-sustaining if we saw more patients per provider. And I think all of the FQHCs would agree that we're at pretty close to the limit. We're going to try to squeeze out another visit here and there where we can, but there's not substantial increases that we can provide. In our case, when you're doing an interpreter-supported visit, it takes you almost twice as long to provide as a face-to-face non-interpreter supported, providing care to someone who speaks English. And you just can't squeeze those other visits in on top of that. And so our providers are incredibly stressed. We've all experienced higher than turnover in our provider groups than ever. If you're a patient, I'm sure you've seen that in our practices. That's stabilizing, but that's really fragile. And us pushing on them to go above kind of industry averages to see more patients is really not possible for us. They're working as hard as they possibly can to keep pace.
We had this discussion in here yesterday. And, to Leslie's point, sort of what everyone else, the work you do is incredible. The work you do is imperative and necessary. It saves costs in the rest of the system. But again, it's a failed funding model, not a failed model, a failed funding model, because we have not funded it.
We did it.
Yeah.
Yes. I mean, you can have a funding model. It's great. It's like, yeah, we'll do it this way. And then you don't actually fund it. That's usually when it fails. But I just can't keep, I keep coming back to, if, would you be able to, I won't use the word thrive, but would you
Survive.
be sustainable if we just paid you for the services that you were providing at a rate that it costs to provide those services? And I think about this particularly in the context of primary care. Because we keep thinking, oh, well, we'll come up with a new funding model. And ultimately, they fail. And to my mind, when you're talking about primary care, you actually want to incentivize more services. That's where you want to incentivize services. So you should be paying primary care for the services that they actually provide, because those services have value for a low cost. And sort of to Leslie's point is, yeah, do we just tweak and change a failed funding model? Do we just inch it along for another couple of years until it becomes a crisis again? Or do we reimagine how we provide the services that our communities need so that it is sustainable and that profitable to provide the services that Vermonters actually need, instead of making it profitable to provide services? You talk about Gifford. If I gave you a big pot of money and just said, here's your pot of money, imagine what you could do to reimagine the services that Gifford is. You would invest it in.
Yes. And we're interested in a global budget, whether it's part of the AHEAD model or not.
I'm not sure I have a question in it. I really
I think
don't
this
have a
was a
question.
great
But
question.
it's an alternative, an alternative payment model. And that's what you're talking
Yeah.
about, and I appreciate hearing you say that. I know there's been huge.
So, I mean, for me, Representative, I agree with Jeff. You're asking a series of good questions. I appreciate your point about failing to fund it. Like, if the feds came to us today and said, well, the FQHC model doesn't work. Well, the fact that you haven't kept up with your grant and inflation for 10 years hasn't helped. The fact that Medicare pays less than Medicaid, that's unusual. That doesn't help. Here, I think for us, if we got paid like independent primary care, hey, here's X dollars for Y code, those are generally less, and just FQHCs would look radically different. Like behavioral health stuff, care coordination stuff, social worker stuff, we wouldn't get paid for it, so we wouldn't be able to sustain it.
Well, no. I'm not saying the way we pay for it now. I'm saying that if we actually paid what it costs to provide services, if we valued the services that we say we valued, if we valued that with a monetary amount, as opposed to.
There are a number of things in that. So we file every year, every FQHC, as do hospitals, a Medicare cost report. We know by the federal formulas how much it costs us to deliver every, per visit, how much it costs us to provide that care. That's part of what you're talking about is a system that's not been in place. And in fact, the state of Vermont has not been compliant with the federal rules on setting rates and having them updated periodically. And now this process we're going through with change in scope has, in our case, us literally going back and reconstructing 25 years of history, because there is not a process in place that we've had and that kept pace across the last 25 years. What we need to do is have the funding in place and then create with DEVA the rules for establishing how we keep pace going forward. The formula is there, the federal mandate is there. It's based on I think often in most cases, in most states, it's based on some formula around your Medicare cost report, your cost per visit. And I think, in my opinion, that still works. If we had created those rules and those procedures through DEVA across the last 25 years, we wouldn't be in that place. So that is a remaining challenge. We need something going forward as well, in addition to the the money we're going to spend to invest in keeping us whole now, to make sure that we don't lose and fall behind again. But that's where we are today.
But your point's well taken. If the DEVA commissioner came to us and said, and what part of what's great about Vermont is to actually talk to another human about this. And the commissioner said, hey, instead of hitting each other with sticks for the next 2 years, which is what we've been doing for 2 years, we wanted to use some sort of payment that is based on cost coverage, right? Like, we're going to cover this amount of your costs. Like, we would be all ears for that type of creative thinking.
I'm
We
gonna
just haven't
I'm gonna go to
been able to
Woody.
get that.
Leslie.
So is reference-based pricing? Is this the answer to all our problems?
I think that is a better discussion outside of the FQHC context.
But you're kind of insinuating that if some of the issues regarding that.
I mean,
in some ways.
I think cost coverage and reference-based pricing are a little different. But I would say with reference-based pricing, I of course want to see the details because I know that the phrase is jumping all over the place. But it really depends on how you set the rules. It could be a really, really good thing. It could be a really, really bad thing. Just someone needs to show me exactly how it's going to work. As putting on my hospital CEO hat, I'm interested in discussing reference-based pricing. I just don't know. I want someone to give me a model that I can actually scrutinize and then take a look at.
I will just, if we did reference-based pricing and we set everything to 100% of Medicare and primary care to 1,000% of Medicare, we would have primary care offices opening everywhere.
Yeah.
So it depends on how it's,
Yeah.
100%.
yes. Topper, and then I think we're gonna, because you did want to talk about the Maple Mountain Consortium, am I correct?
Yes, I mentioned
A little bit more?
but sure, we're happy to talk about it.
I just wanna, you do have a press conference.
Oh,
I'm
okay.
happy to, I have time.
Well, let's do Topper's question and then.
This is gonna be quick.
Okay, got it.
You mentioned global budgets.
Yeah,
Can you get, I don't want you to get into a long discussion.
yeah.
Why do you like them?
Mhm.
Because I know exactly how much revenue I have for the year. And then I know what my job is, which is quality and cost containment.
There you go.
Well done.
Is there anything that you see
How much do you?
in state government in any of the bills that have been put in so far that catches your eye?
No, but that's probably just my own ignorance of the bills.
But that would be really helpful.
I think you should read H.267.
Right. I will take that as
Then call me
bedtime.
up.
It's sponsored by a Representative McFawn.
Call me up.
Thank you. I think we're gonna take a break now and,
Do you want
back?
5 more minutes, wait?
well, we're already,
All right.
we have to be on the floor at 10.
10:30.
30.
The Senate marches in at 10:30.
We've blown through our break. I think no, I think we're gonna go to rural healthcare. I'm not sure if I have actually today's agenda, or it might have been tweaked.
We're supposed to have rural healthcare access.
Elsie and
So,
Lila, Amanda? Are they here?
I don't see Kelsey.
they're outside.
Go see if they're outside.
Thank you.
Thank you. Coming in.
Thank you.
Your press conference.
I appreciate your questions and
Thank
I
you.
even like, that's the best.
Be happy to chat outside.
Just a reminder.
Right, and I do, yeah, do you guys accept paper at all?
Of course, I'd rather have paper. I wanted to, I didn't get a chance to answer my question, but I wanted to ask if there was an opportunity to negotiate about.
Yes.
Oh,
Definitely.
Yeah.
This is a conversation.
I'm always just having-